Today, we surpassed the 8,000 case mark, 8,005. We now have 102 deaths in Ingham County. We are currently monitoring 3,322 cases, and we have 4,581 that have recovered. Basically, since our first case, which I think I look back, might have been March 12th. That was our first reported case. Of course, once we got to onset dates, they date back a little further than that. Monitoring really has to do, again, with all the contact tracing, much of that happening by the Trace Force people that are contractual staff of Michigan Department of Health and Human Services that are basically helping many health departments in the state. Currently, between Sparrow and McLaren Hospital, there are 161 confirmed or suspect cases hospitalized. 148 are confirmed, 128 are on the COVID wing, COVID floors. They usually have a whole COVID floor somewhere in the hospital, and then 20 are in ICU, 16 ventilated. Previous calendar day, so this data was drawn yesterday so that we would be ready for today. So the previous calendar day, emergency department visits are from the 22nd of November. And that number is 41. Hospitalizations since the beginning of the pandemic kind of look like this. This was back in April. Again, we have this data of total confirmed COVID hospitalizations separate from the next graph, because as of August 3rd, the reporting changed, and I just can't get you that data from prior to August 3rd, but we do have this data of just hospitalizations alone. I will say that it does look like we're at least flattening with regard to those hospitalizations. So hopefully that flattening continues and case counts or hospitalizations begin to come down. We are seeing at this point in time a decrease in incidence of cases, hopefully, which would then lead to hopefully, on a little bit of a delay, a decrease in those hospitalizations. So if we look at hospitalization data starting with October 4th, which is when the new reporting came into place, we can see how many COVID patients are on the hospital floor versus the ICU. Then we have the red line under here, which is our ventilated patients, and then the emergency department visits as well. So you can see those emergency department visits are kind of bouncing around there. But really, hovering in around the same place here. We did have a couple of days where we reached nearly 60 emergency department visits on a single day. And those have been trending up since mid-September, really. We had that increase in emergency department visits. They stayed fairly steady for a while and then popped up. This is not in any kind of a 7-day rolling average. If we put this into a 7-day rolling average, it'd smooth out that curve for us. And so this is just day-by-day points. Anytime you look at day-by-day points like that, you'll see a lot of bouncing around, especially for small numbers. While 60 is a lot of people to go to the emergency department on any given day related to COVID, when you have a population as big as we do, 60 still is a small number. So those will bounce around quite a bit, which is one of the reasons you do rolling averages, is to smooth out that bouncing around. Currently, since the beginning of the pandemic, cumulatively, 57.2% of our cases are recovered, 41.5% are active, and 1.3% deceased. So you probably noticed that relative percent of active to recovered is changing. We had like 70 or 70-some% recovered and far fewer active cases back before we had suddenly, 8,000 cases. I think I just looked at the data the other day, and I believe the end of August, we had 1,653 cases, somewhere in the 1,700 cases the end of August, and we're at 8,000 now, which is why you see this dramatic shift in the recovered versus active cases, just because we've just had so many cases in the last 3 months. So here is our cumulative curve. We are still on a climb. Again, we want to see that curve level off and flatten out. and that will be a signal of really, the kind of as we're coming to the end of either a pandemic or a wave or an outbreak. This was an outbreak and then started to level off. So those are the kinds of things you look for afterwards. We had this nice leveling here. The steepness of these curves, of course, kind of obscure what was going on back in June and July quite a bit. If we look at our daily incidence curve, and this is not in any kind of a rolling average, this is what we're seeing right now. So we have had a day right here where we had over 250 cases. We've had days over 200, and we certainly had a number of days over 150 cases in a day. In the last, let's see, this was 150 here. So, since November, basically. Positivity as well has trended up. So we have gone past the 10% positivity mark, and hopefully are trending back down with percent positivity. Our goal would certainly to be get under 7%. Ideally for me, I'd like to see us below 5%, and super ideally, I'd like to see us below 3% or at 3% or below. So when we take both that incident curve and this percent positivity and put those rolling averages on there, you will see that we had a steep curve up and down in September, which goes the positivity also steeply rose and went back down. And then we started seeing this uptick in cases beginning right at the end of October. That has been this recent surge in cases. Those are starting to fall back off, but if you see this right here, that should make us all just a tiny bit nervous that this has some appearances as if it could trend back up, or when you're doing rolling averages, it's kind of hard to tell, because like today's numbers will get averaged in with the previous 6 days. So all of the previous 6 days numbers will change every day that you add new numbers in when you're using 7-day rolling averages. When we look by zip code, we now have 2,401 to 2,410 in 48823. We're at 1,051 to 1,060 at 48911. So really, we've had quite a surge in cases once again in 48911. In this last month, they're kind of, they were way behind 48823, and we've got, less than half the number of cases in 48911, but those have been increasing. Our other zip codes here are, some of them, again, down in this range. We don't even calculate rates for those. Those are small numbers and don't give you a reliable rate calculation. But when we do a rate calculation and put those on the map for you, you see our highest case incidence with East Lansing at the number of cases we saw there. I would caution you in looking at that shading in Onondaga, in that there are only 2,000 people in that zip code, and so it doesn't take very many cases to create a high rate. Anytime you look at a population where the flat population is just really, really low numbers of people, it doesn't take very many cases, and I think there might be 40 or so cases there. East Lansing would have had a rate like that. That's our highest population zip code with, probably thousands of cases or over 1,000 cases, where Onondaga gets into that rate with just, 40 or 50 cases. So a lot of the reason for that darker shading in Onondaga Township is their very, very low population in that area. But that said, over 40 cases in a population where there are only about 2,000 people is also something to be noting. Our heat map, I should have taken that one out, currently looks like this. So you can see we're starting to see, these more pink shaded dots and spots all over the place. We've got a spot up here in, I think this is 48915, and then this is over here in 48823. If we zoom in a little bit on 48823, which is where our, the majority of our, yellow area is in this heat map, you can still see that large mass right here, but I would say that's shrinking, and that's really relative to a lot of the other places coming up and changing just basically the distribution of that heat. And again, I've mentioned several times that when you see these circles like this, the yellow circle with the pink around it, that is typically an apartment complex. So all of those people have the same address while being at a different apartment number. Still cases, 50% are female, 50% are male. We look at age group, we're still with our 20 to 29 age group in our highest at 34%, 10 to 19s at 16%, and then 30 to 39, 40 to 49, 50, 59 in that 10, 11, 12% range. There was a period in time when all of these age groups were roughly the same, although we didn't have that many cases in 10 to 19. So as we have wider spread community transmission, this too is starting to level out, where this age group is starting to shrink down as some of the others as a percent of the total are coming up. By race, 62% Caucasian, 13% African American or Black, 4% Asian, 14% other, and 7% unknown. So if we look at those by rate, 2,297 is our rate for Caucasian population, 3,059 for our African American population. So you do see that disproportionate impact there. And we don't see that disproportionate impact in our Asian population as a whole in the county. I think many of you will recall when we were dealing with the cases in 48911 back in May, we had that significant distribution of illness in our Asian population because of the concentration of folks that were living there in a lot of apartments and housing and things like that. So, you know, if we were to dissect this by zip code, we probably would still see that with our Asian population in 48911. By ethnicity, 76.4% are not Hispanic or Latino, 8% Hispanic or Latino, 15.6% unknown. So when we look at that rate, we do still also see that disproportionate burden of disease in our Hispanic or Latino population at 2,783 compared to our not Hispanic or Latino population at 2,267. And both of those numbers are per 100,000 population. When we look at our deaths by age, we're at 102 deaths now, as we've said. So under 40, and I did mention that individual was 26 last week when we were talking. We still have that 1%. We're at 102, so you know we're basically 1 is going to give us 1%, and then 40 to 49, 2%, 50 to 59, 5.9%. 60 to 69 is 14.7%, and then as has been the trend since the beginning of this, as was seen in Wuhan, China, and across China when this first erupted, the vast majority of deaths over the age of 70, and then particularly over the age of 80, where we see 32.4 and 44.1 respectively % of our deaths. When we look at those deaths by sex, 52.9% are male and 47.1% are female. And when we look at those deaths by race, 20.6% are African American, 74.5% are Caucasian, 1% Asian, and 3.9% other. And I think I've explained a number of times that what we often find in that other category is not necessarily our, Native American, Pacific Islanders, and other populations that typically get put in that other group, but rather Hispanic folks who do not identify as either Caucasian, or Latino folks who do not identify as either Caucasian or Black or African American, and so it gets marked as other. So many of those are basically Latino. If we look, and here's that graph that shows that by ethnicity, not Hispanic or Latino, 90.2%, Hispanic or Latino, 5.9%, 3.9% unknown. just looking a little bit at deaths for you now that we're up to the numbers we are. So just a few things. We have by zip code, 22 of our deaths are in 48823 and 17 of our deaths are 48911. Those are the two populations or the two zip codes with the highest number of cases as well. That does tend to make sense. We also have a couple of long-term care facilities in 48823 where we've had outbreaks and some deaths. So that is part of that as well. When we look at deaths by month, this is what our trend looks like. So we had 1 in March, and then April and May, 11 and 15. Then we spent some time in June and July without deaths and getting things kind of under control. 2 in July, June, 1 in July. Then 10 each in the months of August and September. Then in October, we had 23 deaths, and to date, we have 29 in the month of November. Putting that out by week. So this is deaths by week. I think each of these weeks starts on a Monday and ends on a Sunday. So you will see this represents this week. So obviously we've just started this week. But if you add these numbers together, like say the last 4 weeks, we're averaging about 7.5 deaths a week right now. So definitely, as you can see, 7, 8, 9, 10 deaths in a week we've been seeing at times through late October and early November. And now we still have our MSU related cases by week. That week of September 7th, of course, was our peak at 640 cases. Those were trending downward. And then we did have a little bit of an uptick here on the week of November 2nd and the week of November 9th. Now, we can't draw conclusions about that because actually November 2nd and the week of November 9th, we were having community-wide transmission that was also increasing. So you would expect MSU population related cases to also increase, although they did jump back right down. So I will probably point out to you that MSU U of M game was on October 31st. And so the incubation period for that being anywhere from 2 to 14 days with an average of 5. It's entirely possible that some of these cases we are seeing in this week and in this week could be related to a lot of what we saw related to celebrations after that game. Can't make that conclusion, but we certainly see an uptick in cases in those 2 weeks in MSU related cases. So for right now, we're holding at 48 in this week. As we continue on and we find out onset dates, keep in mind laboratory results are coming in a little bit more slowly at this point in time. So it won't be unusual to see this number change in the next week or so as more of these cases are identified and referral dates or onset dates are put in there and we find cases that actually belong in previous weeks. And that is this week's summary.
Thank you. Does anyone have any questions for Linda? Go ahead, Scott Pohl, please.
Hi, Linda. I tried to get some numbers from the airport today about traffic there, and it turns out I'm not going to get that stuff until tomorrow morning. But have you heard anything about traffic at the airport or the train station or other transportation hubs that have you concerned going into Thanksgiving?
I have not specifically. I mean, anecdotally, I know a lot of students are traveling home. A lot of our MSU students are local or in-state, but some are out of state and are traveling back home. And, just people in general, travel over Thanksgiving to visit family. And while some people are choosing not to do that, some people still are choosing to make those trips and have those gatherings. So I can't give you any kind of quantification of that. I just know that, yes, it is happening. I would imagine at a much, much lower level than a typical Thanksgiving, but not at at a practically nothing level, which is what we'd like to see. You know, we really would like to see travel only be if it's absolutely, absolutely necessary. So I'm sure those numbers are down, but maybe not down as far as we'd like for them to be.
Thank you.
Mm-hmm.
If anyone has a question, please go ahead.
Hey, Linda. And it's probably too soon to be able to make any sweeping conclusions here, but when you're looking at those hospitalization rates and even some of those case rates starting to flatten out a little bit, obviously we haven't made it through the holidays, but I checked in with Sparrow and they said, yeah, that's exactly what they're seeing. Still higher than in the spring, but at least starting to flatten. And we know that they were really worried about hitting capacity as soon as even this week. What do you make of that? What can we kind of bring in from what you guys have been seeing from the health department level?
Wow. Yeah, I mean, this virus has been so difficult to like, well, what do you make of that? It's like, well, there's another odd thing that came along, you know? So there have been many, many, many things about this virus that just make me go, and I have a degree in microbiology. So, you know, you'd think I wouldn't go, so frequently, but I do. You know, I think it's too soon for it to be the result of the new order from the governor, which, you know, put some restrictions in, closed bars and restaurants. We wouldn't see the impact of that soon. Is it possible that, you know, as people saw cases rise, they had let down their guard and guard went back up again? You know, I mean, I will even admit myself, you know, there was a period of time during all of this that if I left my house, the first thing I did when I walked in the door was wash my hands. I had hand sanitizer in my car. I'd get in my car, I'd put hand sanitizer on my hands, I'd wipe down my steering wheel, you know, just to keep my car, you know, a safe bubble. And did I let my guard down a little bit? Yeah, I did. You know, there were times when I didn't always have that hand sanitizer in the car. There were times when I'd get in the house and I'd be like, oh, I didn't wash my hands when I got in the house, sort of thing. So, you know, we've been at this for a long time. And as much as, you know, we hope to ingrain those habits in, we all slip. And I know that I personally, you know, realized that I had let my guard down a little bit. Not bad. I mean, I'm home most of the time, quite honestly. But, you know, let that guard down and really recognize that we're hitting a significant surge in cases. And maybe it's time to get pretty intense about all of these protective factors again. I mean, we were warning people about gatherings and restricting gathering sizes and keeping in a social bubble, keeping, you know, things down to where you're only interacting with maybe one or two other households before the most recent order came. And so, you know, maybe it has had some impact. Or maybe there's some other strange, you know, virology explanation to all of this that just we don't know yet. And we'll find out in the, you know, in the hot wash of all of this after the fact. We'll look back and go, oh, that's why that happened. So hard to say.
Thanks, Linda.
There's no one in the queue, so if you have a question, go ahead, please.
I've got a quick question. It's Rachel.
Go ahead,
Hi, Rachel.
Hello. So I know we've said it plenty of times before, but can you kind of say in a quick soundbite how important it is to you, the health department, about to stay home and not gather with anyone outside of your household during this Thanksgiving or holiday season?
Well, we're in a period of time where we have the highest number of cases we've seen during the entire pandemic. We have the highest number of hospitalizations that we've seen since this pandemic started. We have the highest number of deaths we've seen since this pandemic started. If we want those things to go down rather than continue to go up, then that's what we need to do. We have to take it seriously. We have to protect ourselves in an environment where we just have widespread transmission. We have to, in absence of a vaccine, be careful so that our basic community-wide spread doesn't continue to impact these vulnerable people, older people, people of color who are dying. We look at all these deaths we've had since September. It's a lot. You know, when we started September with 40 deaths, and we're at 102. That's a lot. And nobody wants to basically just have to, go and have a Thanksgiving gathering. And then ultimately we lose grandma because we just had to have that Thanksgiving gathering. So as hard as it is, this is not a time to travel and to gather in groups and multiple households. If you're going to do it, keep it down to just 2 households, less than 10, and be very cautious. That recommendation that you really almost quarantine for some period of time before you do that. It's a little late for Thanksgiving at this point in time, but all of those things are really critical because we're at a time where things could easily take off again. It's like, we got dry wood and dry brush all over the place, and we're going to throw a match into it if we don't be careful.
And then one last one. Are you aware of how cases in Canada went up in Thanksgiving in October? And what would you say to Michiganders to not follow that kind of lead?
Pretty much, it's like we've got evidence that shows that it can happen. And in Canada, they have not had nearly the seriousness in terms of the number of cases and not been able to. They have been able to control this pandemic in Canada far better than us. So if that happened to them, then we are certainly very, very much at risk because we've done a much poorer job of controlling things all along the way. So that's what I would say. It's like if you're looking at Canada and that happened in Canada, it's likely to be even worse here unless we follow these safeguards.
Thank you.
Does anyone have a question? Perhaps we're going to have a short briefing today.
That's okay.
Yes.
It's almost the holiday. Everyone's ready to start.
We'll do one last call for questions. You have a question, Rena?
Yes, can you hear me?
I sure
Yes.
can. How are you, Rena?
I'm doing great. Award for someone who's doing a really magnificent. I think that you deserve it.
Oh, thank you so much.
It's been very, very difficult, but somehow you maintain extreme professionalism, and I really appreciate that.
I think
Quick
I've done
question.
interviews with a few. I'm sorry to interrupt you.
Go ahead.
Oh, I've done interviews with a few of you lately, and I think one of the things I've said lately is it's a darn good thing I used to run marathons. And I did. I used to run marathons, and I guess there's something about me that just knows how to keep on going when everything in you just says, I can't anymore. And you just keep going. So that's what we're doing. We just keep going.
It's a beautiful thing. I have 3 questions, and maybe
Sure.
you can answer them and maybe you cannot. One question is regarding college students coming home. Do you think that the thermometer method is going to work out for families? I've received about 3 calls regarding how to accept your college student back home and worrying them. Should you have a thermometer close by when they get home to take their temperature?
Well, it can't hurt. I will tell you this though, fever oftentimes is a symptom we see a little bit later. So it's not often the first symptom that we see. I mean, we still do temperature screening because that certainly keeps people out of our clinics and things like that if they have temperatures. But if you're using it as a metric of, okay, this person can't possibly be sick because we just took their temperature and they don't have a temperature. Again, people are contagious 48 hours before they have symptoms at all. And oftentimes fever is something that comes after a day or two of some other things. And then some people don't have a fever at all. So it is definitely not it's not a perfect scenario to use that as a protection method. Your best bet really is quarantine for 14 days before you travel, so that when you get home, you know that you are as safe as you can possibly be. Quarantine for 14 days when you return, so that we have the same.
Thank you. My next question is regarding individuals who may test positive twice. Have we had any circumstances where that is occurring, and what are we doing about that?
First of all, people can test positive for significant periods of time after the illness, which is why we don't use, and the CDC does not recommend, it's not in their guidelines, negative testing as a way of, say, return to work or clearance from isolation. So we do see people with lingering positive test results for 60 days or longer. They're not contagious anymore. Most of the stories that we've heard about people not necessarily testing positive twice, because people clearly can test positive multiple times during that window of time and not be contagious. But I think what you're actually getting at is people getting infected with COVID more than once. There is not a lot of really good, strong science around that. There's been some anecdotal stories about that. I think I even heard Dr. Fauci talking about that not long ago. And it's not really clear. It seems more likely that people have, like, imagine, if you do have that lingering virus or whatever, that not really is enough to be contagious, but then, your body goes through a down period, your immune system is down or whatever, and it can have somewhat of a relapse. So he did say that, there are some people that might have a relapse or a resurge in the illness rather than truly having contracted COVID twice. Now, they are talking about seeing immunity waning after a period of time, but that's longer periods of time than what we're talking about with some of these instances of stories of people who have gotten COVID twice. And I would add to that also that anytime there's a novel virus around, it will hit your body hard the very first time it sees it, right? Your immune system has zero recognition to it the very first time when it's a novel virus. And that's why it hits so hard and actually and hits so many people. If you get it a second time, sort of like you can get flu more than once, you can get colds multiple times. Remember, colds are coronaviruses as well. It would be expected that even if immunity wanes, let's say that you have immunity for, say, 2 or 3 years and then could get COVID again, that subsequent infection with COVID should be far less serious. So as we kind of move into our post-pandemic world and into our COVID is going to be endemic and around for however long world, we wouldn't expect to see illness be as serious for somebody who gets it a second time. It's the rest of the people who would be getting it for the first time. And that's where the vaccine, which is proving to be, in the 95% or so effectiveness, is going to be really, really critical for us, because that's great immunity compared to a flu vaccine in terms of vaccination.
The last question, or my last comment, requesting some type of clarification would regarding, do you have any idea why we are shutting down in dining room service, but we're not shutting down big box stores? I'm hearing from my readers that they're closer in proximity and touching more things in the big box stores than they are in dining rooms. And they're kind of upset that they cannot go out to eat any longer. But it seems like that is something that you would logically think about, where they don't have the arrows any longer, you're going in one direction. So I need a little more clarification, because that's been the issue this week.
Yeah, there was a Chicago Tribune article that indicated that about 50% of the people who, during whatever period of time they were looking at it, that had gotten COVID, had also been out, indoor dining. So there was some strong evidence that pointed to that. When you're indoor dining, you're sitting for a period of time, and you're taking your mask off to eat. And so there's that prolonged time in a single spot. Whereas when I go through a store, I'm not staying in one spot in a store for 45 minutes. I'm also not next to the same people for 45 minutes. So close contact really has to do with being in that same space, either closer than 6 feet or without a mask, which will happen in restaurants, which is why the capacity was down, so we could get people spread out for that prolonged period of time. So that kind of respiratory droplet exposure risk is significantly lower in those stores, and they have capacity limits too. The other thing I will tell you, and maybe I can share this article, I'll look it up real quick and put it in the chat, is that the science around the significance of surfaces as a source of contracting the virus is starting to really minimize that. And this is really becoming more of an aerosol and droplet spread virus. Not that we should quit washing our hands, not that you can't get it from surfaces, but a lot of the early studies that talked about surfaces and how long the virus would stay on the surface were done in very, very controlled situations in laboratories where scientists were trying to find out how long will a virus stay on this surface, rather than how long will the virus on this surface actually be able to infect someone. So you're talking about using special chemicals to mimic saliva, you're talking about a specific temperature, a specific humidity, and in absence of light, just to say how long can it survive. You throw that into the real world and it's a completely different scenario. So I've seen a couple of articles recently. One might have been in the New York Times, but the one that I refer to frequently is from Wired, which Wired is probably, I don't know that much about Wired as a news source, but it does cite a number of studies and kind of explains that phenomenon and kind of asks us to really kind of reconsider the significance of surfaces as a source of transmission. And what they kind of say in here is really for us to get COVID from surfaces, someone would have to sneeze, cough, or whatever, put, droplets onto a surface, and in a significant amount, because you have to have enough viral load for it to actually infect you. Then you would have to touch it really shortly afterwards because it degrades so fast in a typical environment rather than a laboratory controlled environment. And then you would actually have to touch your eyes, nose, or mouth fairly quickly after that in order for the surface to be as significant of an issue as at one point in time we thought that it was. So the science has really shifted with regard to surfaces. Really, I think early on we thought surfaces were kind of the primary route of transmission, and really more the primary route is these aerosols and droplets, and less so surfaces, which really kind of makes sense when you see the distribution of illness. If it was so prevalent on surfaces and so easy to get from surfaces, I think we would see a whole lot more cases. But check out that Wired article. It refers to a number of studies that I was talking about. One was done in Australia, and I think it showed virus staying on surfaces for like 28 days, which kind of freaked some folks out. And then I read the actual study, and it's like, oh, you cultured the virus and all this special stuff. It had antibiotics and all kinds of things in it. So you created like really a perfect world for the virus. Then you put it on surfaces in the dark at a certain temperature, at a certain humidity, and then measure how long is this virus still here. And that doesn't tell you whether that virus, even if it's still on that surface, whether it is actually capable of getting into somebody's bodies and being replicable. So it doesn't necessarily say that it's a replication competent virus unless you also take it off that surface and then culture it rather than just detect its DNA from some sort of a PCR kind of test. So I would say that probably is the reason why.
Okay,
and then the other is that while food is essential, dining indoors is not. So we have to have grocery stores. We have to be able to get food. Those things sustain life. So the decisions were made early on about what things were considered essential back in April, May, when everything was, March, April, excuse me, when things were shut down. The big box stores were open then, considered as essential services. I can see your point that arguably maybe some of them not quite so much, but if your toilet's not working, you do need, a Home Depot or a Lowe's or whatever to keep from having sewage, overflow your house. So there are some reasons why some of them are open. In terms of basically, sustaining life and essential things for us to continue to go about our lives.
My last question has to do with the healing of the body after you have contracted the coronavirus. How is our community doing regarding healing? I'm looking at television and seeing a lot of people who are having after effect illnesses. How is our community doing as far as their healing is concerned?
I think we're seeing what's being seen just in general with this virus, which is that there are people who have longer term consequences after the illness. Other people just move on. Heart involvement and other kinds of things. It's really hard to tell. I mean, we're 9 months into it, so we only know 9 months worth of information in terms of whether or not somebody eventually, completely recovers from any of those long-term consequences that are possible there. So, we see some of that as well. We see people who are, still struggling with different things, fatigue, lung issues, those sorts of things. And we see other people that recover and don't have those issues. So it's a real mixed bag. And that's, one of the reasons we ask people to be extremely cautious is that, we really still don't know what the potential long-term consequences of being infected with this virus are for some people. Not everybody, but certainly for some people.